Hello and welcome. I'm Sandra Lopez, a Doctor of Nursing practice student at the Catholic University of America. I truly appreciate your time and participation in this evidence-based practice project. Today, we're exploring how Critline technology enhances fluid management in hemodialysis, ultimately improving patient outcomes through real-time data. I chose this topic because I'm passionate about using evidence-based practice to improve care and elevate the discipline of nephrology nursing. Managing fluid levels effectively is crucial for dialysis treatment safety and success, and Critline offers a valuable tool to support that goal. For this project, we'll assess nurses' perceptions of Critline monitoring using a modified technology acceptance survey. So here's what you can expect. First, you'll take a pre-survey to gauge your familiarity, ease of use, and confidence with Critline. Then I'll present its clinical benefits, setup, and practical application. Finally, you'll take a post-survey to reflect on what you've learned. Once you complete all 3 steps, you'll receive a $50 stipend as a token of appreciation for your participation. Your insights are incredibly valuable in shaping the future of nephrology nursing. Thank you for being part of this important initiative. Before we dive into this presentation, please note the following disclosures. I'm not a current employee or affiliate of Fresenius Medical Care Renal Therapies Group, and I have no financial relationship with Fresenius Medical Care related to this project. Additionally, the information presented here supports clinical decision-making and should not replace the judgment or experience of the attending physician or other medical professionals. The treatment prescription remains the sole responsibility of the attending physician. ESRD affects 2 million patients worldwide and 500,000 in the United States, with 400,000 undergoing outpatient hemodialysis. In terms of morbidity and mortality in the dialysis patient population, cardiovascular disease is the leading cause of both complications and death, with an average life expectancy of about 5 years. If the patient also has congestive heart failure, their prognosis worsens significantly. Approximately 80% of these patients will not survive beyond 3 years. Fluid overload in dialysis patients can cause severe cardiovascular issues like hypertension, left ventricular hypertrophy or LVH, and heart failure. Effective fluid management aims to achieve euvolemia by removing excess fluid through ultrafiltration. However, overly rapid ultrafiltration may result in hypovolemia or intradialytic hypotension, also referred to in the literature as IDH, and intradialytic complications such as cramping and dizziness. Balancing fluid removal with plasma refilling is critical, highlighting the need for precise monitoring to ensure better patient outcomes. The clinical practice problem under consideration is determining dry weight in dialysis patients. Determining dry weight is complex and often subjective, and traditional assessments such as weight, edema checks, and blood pressure measurements often fail to reflect intravascular volume status accurately. Fluid overload or hypervolemia increases the risk of hypertension, pulmonary edema, and cardiovascular complications. Conversely, hypovolemia can cause hypotension, dizziness, cramps, and organ ischemia, often mistaken as routine dialysis side effects rather than signs of poor fluid management. Relative blood volume monitoring with Critline technology provides real-time data to optimize fluid removal, reduce complications, and improve outcomes. Without it, treating intradialytic hypotension, also known as IDH, or intradialytic morbidities, also referred to as IDMs, rely on reactive measures such as albumin, saline, or midodrine administration rather than addressing the root cause. Before we review today's agenda, consider an analogy. Think back to 1955 when seatbelts were first introduced. Only 2% of customers opted in, while 98% dismissed them as unnecessary. Later that year, Ford installed seatbelts in all its models for just $27 per vehicle, equivalent to approximately $190 today. This small decision revolutionized road safety and saved countless lives. So how does this compare to Critline? Blood volume monitoring emerged in the 1990s but remains largely absent outside Fresenius medical care facilities. Some dismiss it as a luxury rather than a necessity, while others prefer to avoid the hurdles of implementation. Just as seatbelts reshape driving safety, Critline can redefine patient safety in hemodialysis. Today's agenda includes a brief video overview of Critline and a pre-survey. We will review current research, then walk through the process of initiating treatment, monitoring fluid removal during dialysis, and ending a treatment. To bring everything together, we'll explore a case study demonstrating the application of these principles and techniques in clinical practice. Finally, we'll conclude with a post-survey. Thank you for participating today. We hope you find the session valuable as you explore how Critline technology can enhance your practice. Now let's watch a brief video on relative blood volume monitoring, its role in dialysis, and its benefits to patients.
The kidneys are highly perfused organs that effectively and rapidly remove waste molecules and excess fluid. Filtration occurs within glomerular capillaries and forms urine. Worldwide, millions of people suffer from chronic kidney disease. This affects waste filtration and causes fluid retention, leading to around 2 million patients requiring hemodialysis. During hemodialysis, critical blood parameters such as hematocrit, relative blood volume, fluid removal by ultrafiltration, and oxygen saturation can be monitored to help limit common intradialytic symptoms such as dizziness, cramping, and vomiting. Removal of intravascular fluid during hemodialysis reduces blood volume, leading to an increase in the hematocrit. This causes a shift of interstitial fluid into the vascular space, known as plasma refill. As plasma refill occurs, blood volume increases and hematocrit decreases. Therefore, changes in blood volume and hematocrit can be used as indicators of effective hemodialysis. Critline technology can continuously and non-invasively measure these parameters to limit intradialytic symptoms. During dialysis, a Critline sensor clip is attached to a blood chamber between the arterial bloodline and the dialyzer. Optics within the sensor clip can emit multiple wavelengths of light, illuminating the blood as it passes through the chamber. This allows measurement of hematocrit, percentage change in relative blood volume, and oxygen saturation. These measurements are displayed on a monitor and updated in real time throughout the treatment. Also displayed is the patient's percent change in relative blood volume, represented as profile A, B, or C. These profiles monitor the relationship between the patient's plasma refill rate and the ultrafiltration rate. Profile A is represented as a flat or slightly positive slope. This indicates that the patient's rate of plasma refill is the same as or slightly greater than the rate of ultrafiltration, suggesting that the ultrafiltration rate may be increased without the risk of immediate intradialytic symptoms. Profile B is represented as a gradual slope and has been targeted to find the best compromise between a high ultrafiltration rate and the prevention of intradialytic symptoms. Profile B indicates that the patient's plasma refill rate is slightly less than the rate of ultrafiltration, and hemoconcentration of red blood cells is increasing. The ideal slope is not a fixed percentage of change in blood volume and can vary from patient to patient. Profile C is represented as a steep slope. This indicates a rapid decrease in blood volume and significantly higher hemoconcentration of red blood cells due to a high rate of ultrafiltration, bearing a higher risk of intradialytic symptoms, which include cramping, dizziness, and vomiting. Allowing clinicians to monitor blood volume continuously throughout a treatment and make appropriate clinical adjustments in real time, Critline technology can help provide patients a more effective dialysis treatment. Critline technology provides real-time clinically relevant parameters that help clinicians to optimize fluid removal, maximize ultrafiltration, and reduce the risk of intradialytic symptoms in dialysis patients.
Before we continue, please complete the survey sent to you via text or email, or access it using the QR code here or on the project flyer. It only takes a few minutes, and your responses will provide valuable insights to enhance patient care. Thank you for your participation. Thank you for completing the survey. We will now discuss the prevalence and impact of fluid overload. Studies have shown that nearly half of the hemodialysis population is fluid overloaded, placing a constant strain on the heart and leading to complications like left ventricular hypertrophy or LVH. This progressive cardiac remodeling not only worsens heart failure, but also increases the risk of hospitalization. Studies consistently show a significant association of fluid overload with all-cause cardiovascular mortality. Studies have also shown that blood pressure and clinical physical assessment alone are not sensitive enough to identify fluid overload. In 2010, Agarwal investigated the impact of fluid overload on the survival of dialysis patients. The study followed 308 long-term dialysis patients across 4 clinics and measured changes in their blood volume during treatment. The key finding was that patients whose blood volume did not drop much during dialysis and had a flatter RPV slope had a 72% higher risk of death. This suggests that many patients were chronically fluid overloaded, which increased their risk of morbidity and mortality. While hypertension is often associated with excess fluid, it doesn't tell the whole story. A study conducted in New York City in 2022 aimed to investigate this by utilizing bioimpedance spectroscopy to measure fluid status in 170 urban hemodialysis patients. Their findings highlighted a crucial gap. Although there was some correlation between fluid overload and high blood pressure, only 48% of fluid overloaded patients were hypertensive. In other words, more than half of the fluid overloaded patients did not present with high blood pressure. This highlights the limitations of relying solely on blood pressure to assess fluid status and underscores the need for more precise evaluation methods. Sakali et al. In 2021 also highlights the limitations of blood pressure as a fluid status marker. Patients with fluid overload only had a 7.8 millimeter of mercury higher pre-dialysis blood pressure than those with normal fluid status. This minimal difference proves that blood pressure alone lacks the sensitivity to detect all cases of fluid overload. Given the high prevalence of fluid overload in dialysis patients, in 2016, Hussein et al. Examined the proportion of patients whose target weight was adjusted based on blood volume monitoring results. The study included 169 patients from 5 dialysis centers, revealing that 43% were still fluid overloaded despite clinical assessments, suggesting that they had reached their target weight. Patients who frequently experienced blood pressure drops or IDH were more likely to be in this fluid overloaded group. Additionally, 40 patients initially thought to be dry were found to be carrying excess fluid, highlighting the limitations of traditional clinical and physical assessments. The body relies on a delicate balance of fluids to maintain organ function and overall health. Disruptions in this balance, whether from fluid overload or hypervolemia, or fluid depletion or hypovolemia, can have severe consequences. The illustration on the right highlights how both conditions impact organ function. Insufficient fluid reduces blood volume, lowering vascular pressure and limiting oxygen to vital organs, which can lead to organ failure and in extreme cases, death. Conversely, excessive fluid intake strains the heart, forcing it to work harder to circulate the excess volume. This can overwhelm the cardiovascular system, dilute oxygen levels, and further impair organ function. The diagram on the left demonstrates the widespread effects of fluid overload. In the brain, fluid overload can cause confusion and cognitive issues. Excess fluid in the lungs makes breathing difficult and reduces oxygen exchange. The kidneys struggle to eliminate toxins, leading to salt and water retention. Tissue swelling slows wound healing and increases infection risk, while gut edema interferes with digestion and nutrient absorption. Even the liver and heart are affected. Congestion impairs liver function, and fluid buildup weakens heart contractions. For nurses, the takeaway is clear. Monitoring fluid balance is essential. Starling's law and Laplace's theorem explain how excessive fluid retention increases myocardial wall stress and oxygen demand, contributing to hypotension during dialysis, not just hypertension. Starling's law states that the heart's contraction strength depends on the degree of the stretch before contraction. While moderate stretching enhances contraction and stroke volume, excessive stretching raises oxygen demand, leads to hypotension, and reduced cardiac output. Overfilled blood vessels overstretch the heart muscle, increasing wall tension and diminishing output. Thus, intradialytic hypotension, or IDH, can result from both a wet or dry crash, indicating that excessive fluid removal is not the sole cause of hypotension during dialysis. Both fluid overload and depletion can severely damage organs, underscoring the importance of careful monitoring and management. As dialysis nurses, we play a crucial role in ensuring safe, effective, and precise fluid removal to prevent life-threatening complications and achieve the best patient outcomes. Here's another look at the effects of intradialytic hypotension, or IDH, the most frequent complication of hemodialysis, which can result in severe health complications including myocardial stunning or damage to the heart muscle, reduced brain blood flow or cerebral hypoperfusion, gut damage caused by ischemia, loss of residual renal function, severe symptoms like fainting, chest pain, and abdominal pain, and increased risk of death. IDH occurs when blood pressure drops too much during dialysis, leading to poor organ perfusion. However, not all blood pressure crashes are due to high fluid removal rates, so it's essential to identify the underlying cause for proper management. Here's where Critline can help. Properly managing fluid balance is key to preventing complications like IDH. While IDH is often linked to excessive fluid removal, fluid imbalances in either direction, whether too much or too little, can significantly impact patient outcomes. Achieving an optimal dry weight is essential for stabilizing blood pressure and minimizing the need for antihypertensive medications. This is why the latest KDOQI 2022 guidelines emphasize personalized and evidence-based strategies such as blood volume monitoring to improve fluid management and reduce the risks associated with both fluid overload and hypovolemia. Now let's explore the evidence surrounding Critline. Research consistently demonstrates the critical role of fluid management in dialysis survival. Agarwal's study found that patients with less aggressive fluid removal and flatter RBV slopes, indicating inadequate ultrafiltration, had a 72% higher risk of mortality. This underscores the need for precise fluid removal strategies. Ficocchiello's research further supports this, revealing that patients with minimal RBV reduction were at a 16 times greater risk of death than those with significant RBV reductions. This finding reinforces the importance of achieving appropriate fluid removal targets. In Preciado's study, patients who experienced specific RBV changes during the first 3 hours of dialysis had significantly lower all-cause mortality. Together, these studies provide strong evidence that real-time RBV monitoring is essential in dialysis care. By using Critline to fine-tune ultrafiltration rates and prevent both under and over fluid removal, we can enhance patient safety, reduce complications, and ultimately save lives. Real-time monitoring of a patient's hemodynamic status during dialysis provides valuable insights that help clinicians anticipate and prevent intradialytic hypotension, or IDH. Research by Chatoyer and Keene show that tracking these changes in real time allows for early intervention, reducing the risk of complications and improving treatment stability. Beyond predictive capabilities, real-world data supports the use of Critline as a key component of fluid management programs. Studies by Preciado, Parker, and Balter demonstrate significant benefits, including a 35 to 50% reduction in both all-cause and fluid-related hospitalizations, as well as lower overall mortality rates. These findings highlight the impact of precise volume management on patient survival and healthcare utilization. Moreover, appropriate volume management with Critline has been directly linked to improvements in key clinical outcomes. Research by Balter, Sybil, and Ho indicates that patients experience meaningful reductions in systolic blood pressure, reduced reliance on antihypertensive medications, and lower ESA doses. These benefits not only enhance patient health but also contribute to more efficient and cost-effective dialysis care. Together, these studies reinforce the importance of integrating Critline into dialysis practice. By optimizing fluid removal and hemodynamic stability, we can improve overall patient safety, reduce hospitalizations, and enhance overall treatment outcomes. A 2019 study by Preciado et al. Followed 842 dialysis patients for approximately 31 months to investigate the impact of changes in blood volume during treatment on survival. They found that patients with more stable and gradual blood volume changes had better survival rates, suggesting that maintaining steady fluid levels during dialysis may help reduce the risk of death. A study by Balter et al. In 2015 examined the impact of relative blood volume monitoring using Critline across 15 hemodialysis clinics over 1 year. The findings demonstrated that patients whose fluid removal was guided by Critline experienced fewer hospitalizations and overall improved outcomes, underscoring the critical role of effective fluid management in dialysis care. However, successful implementation of Critline requires the following key elements: strong physician support, comprehensive clinician training, and a structured onboarding process for new staff to ensure consistency in practice. We have reviewed multiple studies demonstrating Critline's benefits in reducing hospitalizations, improving survival, and enhancing blood pressure control. However, one study presents a different perspective. The CLIMB study by Redden et al. In 2005 reported higher hospitalization and mortality rates among Critline patients. However, its short duration, unequal randomization, and aggressive fluid removal rates of up to 8% per hour limit its conclusions. Additionally, the study did not assess hospitalization causes, leaving uncertainty about whether admissions resulted from fluid management or unrelated factors. Excessive fluid removal and poor protocol adherence, particularly in CHF patients, may have skewed CLIMB's findings. In contrast, individualized removal, typically around 4% per hour, ensures a safer treatment. Despite CLIMB's limitations, extensive evidence supports real-time monitoring like Critline for safer, more effective dialysis care. In 2005, Rodriguez et al. Studied whether Critline monitors could help determine a patient's true dry weight by assessing how their blood volume refilled after dialysis. In this study, all 28 patients had their dry weight adjusted based on Critline data and clinical symptoms. 19 patients had their dry weight lowered, indicating they had excess fluid that could be safely removed. 9 patients had their dry weight increased, suggesting that they were too dry. The findings showed that blood volume monitoring, or BVM, when combined with clinical judgment, helped achieve a more accurate dry weight, leading to better fluid management in dialysis patients. Knowledge of plasma refill and compartment shifts can help in understanding intradialytic events and improve fluid removal. Jabara et al. Assessed the relationship between blood volume changes and plasma refill. They demonstrated that in the absence of ultrafiltration, relative blood volume monitoring could detect whether fluid was shifting from the extracellular to the intravascular space. By performing a refill check, clinicians can assess whether plasma refill is occurring. The graph on the left shows the relative blood volume change becoming more positive or fluid entering the bloodstream when the UF is off, and the graph on the right shows a treatment without plasma refill. The blood volume change remains the same in the absence of ultrafiltration. Critline technology also provides clinicians with the ability to continuously monitor oxygen saturation status during dialysis. Several recent studies have demonstrated an association between lower intradialytic SaO2 or ScVO2 levels and poor outcomes. Chan et al. Demonstrated an association between lower intradialytic ScVO2 and shorter survival time. Meiring, Woston et al. Demonstrated an association between prolonged intradialytic hypoxia, SaO2 less than 90% for at least one-third of the treatment, and lower survival probability. Now that we've covered the role Critline plays in fluid management, I will review briefly how to set up and start a treatment using the Critline monitor. Here is an image of the Fresenius 2008T dialysis machine with a Critline software upgrade. Critline monitoring with the 2008T dialysis machine requires the click device shown at the top right, which attaches to the screen via USB. The clear verification filter attaches to the IV pole and is where the click device can be stored while not in use. The Critline is also available as a separate monitor, as you see on the bottom right, allowing it to be used with any HG system as long as the appropriate blood chamber is available to be attached to the dialyzer. Here is an image of the Critline click device connecting to the blood chamber on the dialyzer. The entire process is external and non-invasive. Here you can see a close-up of the click verification filter, the USB connector that plugs into the screen, the Critline click, and the blood chamber to which the click device connects. The blood chamber connects to the dialyzer using a Luer lock connection. The arterial blood line is securely twisted into the top of the blood chamber and then attached to the arterial side of the dialyzer. Here's a close-up of the verification filter on the IV pole used to verify the device's accuracy. The click clip sensor should be kept on the verification filter when not in use. A simple software upgrade to the 2008T machine combined with the installation of the click device provides additional menu options such as verifying accuracy on the Test and Options tab, which is typically performed during machine testing to verify the click device. Although it's only required once every 30 days, every time the machine is placed into test, it will automatically verify the click device as long as the click sensor is on the verification filter. Once the machine has passed test and accuracy has been verified, prime the system. Inspect the blood chamber to ensure it is free of air bubbles or leaks. After 60 seconds, the Critline will begin grafting a slope representing the relative blood volume change. Here you can see the Critline monitoring screen, which provides real-time continuous data to help guide fluid management during dialysis. This is the screen displayed throughout treatment. As fluid is removed, you will observe and respond to changes in the relative blood volume curve and the patient response. This is a close-up of the Critline main screen. The x-axis represents treatment duration in hours, while the y-axis shows the percentage change in blood volume. The graph tracks blood volume changes over time, helping customize target percent changes per hour based on patient comorbidities. At the top right-hand side of the screen, you'll see the hematocrit and the hemoglobin values. Below the hemoglobin, the relative blood volume percentage is shown. The blood volume alert level to the right helps indicate when the patient may be approaching a critical point in volume depletion, alerting the clinician to adjust ultrafiltration accordingly. The screen also continuously monitors oxygen saturation displayed alongside an O2 alert level on the right, which can indicate whether the patient is experiencing hypoxia or poor perfusion. In the middle of the screen, a graphical representation of relative blood volume change trends over time, allowing for easy tracking of the patient's response to dialysis. A sharp drop in the graph signals that plasma refill is insufficient, increasing the risk of symptoms like cramping or hypotension, while a gradual decline indicates a more stable fluid shift. At the bottom of the screen, additional treatment parameters are displayed, including treatment time remaining, arterial pressure, venous pressure, transmembrane pressure, ultrafiltration goal, UF rate, UF removed, dialysis flow rate, temperature, conductivity, blood flow, and even the heparin infusion rate and KCN. Since the Critline main screen gives the best real-time picture of fluid shifts, it's recommended that the dialysis treatment be left on this screen during the session. This ensures the care team can monitor changes and intervene if necessary, leading to safer and more effective management. The patient profiles provided by Critline give clinicians a continuous, real-time visual of how the patient tolerates the UFR, or the ultrafiltration rate. The profiles are classified by the Critline monitor as A, flat or slightly positive curve, B, a gradually declining curve, or C, a steep declining curve. While a B curve represents the best compromise between ultrafiltration and avoidance of intradialytic symptoms, both A and C curves may indicate situations that could warrant intervention. Here's a picture of profile A, represented with a flat or slightly positive slope. This profile is displayed when the measurements taken over the previous 15 minutes result in a profile that is less than or equal to minus 3% per hour, which indicates that the patient may have more fluid to remove. The UF goal may need to be increased. Plasma refill occurs at the same or greater rate than the ultrafiltration rate, and the ultrafiltration rate may be increased without immediate intradialytic symptoms. Here you can see profile B. Profile B is displayed when measurements taken over the previous 15 minutes result in a profile that is over 3% per hour and less than or equal to 6.5% per hour. It is a gradual slope, which is the safest fluid removal rate for most patients. The ideal slope is not a fixed percentage of blood volume change and will vary from patient to patient. Here you see the red arrow near the slope, which shows what a B profile looks like. The vertical lines on the graph highlighted in yellow are indicators of the hours of treatment, so I would interpret this graph as an A profile during the first hour of treatment and a B profile during the second hour. Here you see profile C. Profile C, represented with a deep declining slope, is displayed with the measurements taken over the previous 15 minutes, resulting in a profile that is greater than 6.5% per hour. This profile is usually associated with intradialytic hypotension, or IDH. Here you can see how much steeper the slope is in this picture, which bears a higher risk for adverse events or symptoms. Once treatment has started, the Critline will begin to graph the percentage change in blood volume within about the first 60 seconds of treatment. During treatment, you will monitor key data points, including blood volume changes and oxygen saturation levels. You will adjust the UF goal as needed based on your Critline assessment, but always prioritizing patient signs and symptoms first. During the last 10 minutes of treatment, you can reduce the ultrafiltration rate to minimum and check to see if there is vascular refill by following these steps. First, reduce the UF and record the hematocrit. Wait 10 minutes. Then record the hematocrit again. Subtract the second value from the first. If the result is greater than or equal to 0.5, the patient has refill, indicating that there may be additional fluid available for removal. If it is less than 0.5, no refill is present. Here is a refill check example. At the end of treatment, we take a hematocrit reading, say 35, and a patient with a B profile, indicating appropriate fluid removal. After lowering the rate to minimum and waiting 10 minutes, the hematocrit drops to 34.2. Since the difference is greater than or equal to 0.5, indicating vascular refill, fluid is shifting back into the bloodstream. This suggests the patient may safely tolerate more fluid removal in future sessions. Using the data-driven approach helps optimize fluid removal while maintaining patient stability and preventing complications. When the treatment is complete and the treatment clock is paused, pinch the sensor clip and gently remove it from the blood chamber and place it back on the verification filter, which is attached to the USB cable. Discard the disposable Critline blood chamber with the rest of the blood lines. The exterior of the click device can be cleaned at the end of every treatment with an approved hospital disinfectant. The following study presents a 5-hour dialysis treatment enhanced through video acceleration to illustrate how Critline functions in clinical practice.
Let's take a moment and review the medical history of patient 1. Patient 1 is a 52-year-old African-American male with type 2 diabetes. He is legally blind. He has a right below-the-knee amputation and wears a prosthetic leg. He underwent a left fifth toe amputation secondary to gangrene. Hemodialysis was initiated in 2001. He undergoes a 5-hour treatment via permacath with a consistent history of cramping during the last 30 to 45 minutes of treatment. While non-compliant with treatment for many years, he has not missed a treatment in over 4 years. He lives independently at home with maximum home care services. Let's quickly review some key pre-treatment data. Patient 1's estimated dry weight prescription is 101.50 kilograms. Pre-weight was 101.60 with a last post-weight of 100 kilograms. The clinical team set the initial ultrafiltration goal for 1,200 milliliters, with an ultrafiltration rate of 240 milliliters per hour for the 5-hour dialysis treatment. At the start of dialysis, patient 1's initial blood pressure was 176/107. Readings from the Critline monitor indicated an initial hemoglobin of 12.4 and starting hematocrit of 36.4. During this treatment, the nurse requested a physician order to administer oxygen via nasal cannula based on long history of consistent cramping during last 30 to 40 minutes of treatment. 21 minutes of treatment time has elapsed for patient 1. If you look at the screen, you will notice the following. The letter C is shown in the profile letter box in the right top corner. However, when you look at the full picture of patient 1's machine screen, you will notice the blood pressure is 158/90. Heart rate is 94. The percent of blood volume change is -2.6% and the slope is flattened out. Although it says the patient is in a C profile, the patient is stable, so no interventions are necessary. As we continue to observe over the next several minutes, you notice the percent of blood volume change is continuously fluctuating between -0.8% and -3.2%. The trending profile letter has changed as well, originally a C, but then to a B, and now an A, which would be the appropriate indication that the patient's plasma refill rate is exceeding the set ultrafiltration rate programmed. After getting the remainder of her patients on the machine, the caregiver has returned to patient 1's chairside. Based on the assessment of the patient, blood pressure of 158/90, heart rate of 94, and a blood volume percent change of -1.2%, an increase of 200 milliliters was added to patient 1's goal. This will bring it from the initial goal of 1,200 milliliters to 1,400 milliliters. 10 minutes have gone by, and you will still notice that despite increasing patient 1's ultrafiltration goal by 200 milliliters, the percent of blood volume change is still fluctuating between minus 0.6 and minus 1.9%. A second intervention is made. Another 200 milliliters is added to patient 1's ultrafiltration goal, bringing the total ultrafiltration goal to 1,600 milliliters. After this increase of an additional 400 milliliters per hour, the percent of blood volume change continues to fluctuate. This indicates the patient is refilling their vascular space faster than the set ultrafiltration rate. Now, a full hour into treatment, we notice not much has happened with his percent of blood volume change. It continues to fluctuate, and the slope continues to be in a flat position. This indicates that the patient's plasma refill rate continues to exceed the set ultrafiltration rate. A half hour from the last intervention has passed. Based on patient 1's assessment, blood pressure of 175/99, heart rate 93, and previous percent blood volume change, the caregiver decides to increase the goal by another 200 milliliters to a total of 1,800 milliliters per hour, hoping to optimize fluid removal. For a short time, it appears we are gaining momentum in removing fluid based on the percent of blood volume change fluctuation between minus 1.7% and minus 3.7%. However, we learn quickly this is short-lived. For timing purposes, the film is speeding up quite quickly. However, if we look closely enough at patient 1's percent of blood volume change, you will notice that even after 1 hour and 25 minutes into treatment, patient 1 remains in a positive fluid balance. In the last 10 minutes, you notice another intervention marking on the screen. The percent of blood volume change is minus 0.7%, but the caregiver did not make an increase in the goal. Since it was only 10 minutes after the last increase and the blood pressure had decreased to 144/93, it was decided to wait until the next blood pressure check to intervene. Throughout this waiting period, however, patient 1's percent of blood volume change is still fluctuating between a positive and a negative fluid balance. A fourth intervention was completed, adding an additional 200 milliliters to patient 1's goal. This has added an additional 800 milliliters to patient 1's ultrafiltration goal. Please note, the profile letter box in the upper right-hand corner shows an A profile, and patient 1's percent of blood volume change indicates such at minus 0.5%. We see very little change in fluid shift at this time. The blood pressure has increased to 179/109 and heart rate 92. No interventions were completed due to timing as per the facility protocol. Here we notice patient 1's percent of blood volume change is fluctuating between a positive and negative percent. You see patient 1's blood pressure decreased to 132/86, heart rate 94. Patient 1 is resting comfortably and has no complaints. After assessing patient, the caregiver decides to increase the ultrafiltration goal by 200 milliliters. The percent of blood volume change is at minus 0.2% after 2 hours of ultrafiltration, indicating an increase is necessary. This increases the total ultrafiltration goal by 1,000 milliliters from the initial goal of 1,200 milliliters. When observing the slope, you may notice a slight sharp decrease for a very short time. The profile letterbox has changed to show a C. However, there is no indication patient 1 needs an intervention. The blood pressure is stable at 159/102, heart rate 94, and the percent of blood volume change is minus 2%. Patient 1 is sleeping. New blood pressure value shows 133/99, heart rate 95, and percent blood volume change is minus 2.4%. No intervention is needed. Based on the newest blood pressure reading of 146/77, heart rate 93, 30 minutes later, another 200 milliliters was added to patient 1's goal. After 3 hours into patient 1's treatment, we are finally seeing a consistent percent of blood volume change. This is a total of 1,200 milliliters added to the initial goal set when patient 1's treatment began. Even with an increase of 1,200 milliliters per hour to the initial goal, patient 1 still shows fluctuation in his percent of blood volume change. Patient 1's slope is heading in a downward spike. The blood pressure is 144/96, and we are successful in getting to a minus 5% blood volume change, but not for too long. As we watch the blood pressure decrease slowly to 132/84, we can still notice the percent of blood volume is still fluctuating. This is a clear indication that patient 1 still has continual plasma refill. After another 30-minute interval, the caregiver decided to increase the ultrafiltration goal by another 200 milliliters. This is 1,400 milliliters more than the initial goal set at the beginning of patient 1's treatment. Another blood pressure value is taken at this time. Blood pressure remains stable at 148/76, heart rate 91. He is resting with no complaints. Here we see a shift in the screen. Because patient 1's treatment is 5 hours, you see the treatment screen rescale to allow for the 4th hour. Again, this has no effect on the patient's treatment. We are almost into the 4th hour of patient 1's treatment. Blood pressure is decreased to 120/74, heart rate 93. The ultrafiltration rate currently is 730 milliliters per hour. However, the percent of blood volume change is still sitting at -4%. Patient 1's blood pressure is the lowest it's been throughout the treatment. There is no sign of instability, and patient 1 reports feeling okay. Based on current blood pressure reading, the caregiver decides to just observe patient 1 and check his blood pressure every 15 minutes rather than every 30 minutes. Patient 1's blood pressure rebounded and is now at 129/74, heart rate 92. Based on patient 1's assessment, the caregiver decided to increase patient 1's ultrafiltration goal by 100 milliliters. Five minutes after the last increase, you see the percent of blood volume change increase to -5.5%, which is what we have been waiting to see. The slope, however, is heading in a downward spike, and the profile letterbox shows a C. Based on patient 1's assessment, the caregiver did not decrease the goal, but rather observed patient 1's slope and percent blood volume change for a rapid decrease. After 4 hours and 35 minutes into patient 1's 5-hour treatment, the blood pressure is 129/38, heart rate 93. The slope that was heading in a downward spike has leveled out once again, and the percent of blood volume change is -6.6%. Patient 1's treatment screen rescales again to accommodate the long treatment time of 5 hours. Again, there is no impact on the patient's treatment. Current hematocrit is 38.8, hemoglobin is 13.2, and we see a 6.2% reduction in blood volume at this point in the treatment. While the trending profile indicates an A profile, patient 1's refill has decreased steadily, as evidenced by the steady reduction of blood volume percentage. Blood pressure has increased to 139/77. At the end of patient 1's treatment, his blood pressure is 135/63, heart rate 93. Patient 1 is feeling well at the end of his treatment. He has experienced no cramping, as he has done every treatment in the past. We achieved a -7% blood volume change. Let's review some of the lessons learned from patient 1. Without access to the data from the Critline monitor, the clinical staff would not have had the information to adjust treatment to remove 2,603 milliliters of fluid, 1.4 liters above the initial ultrafiltration goal set. The Critline data suggests that the initial goal might not have been set correctly. Initial ultrafiltration goal calculation is an extremely important step in effective fluid management. The ultrafiltration goal was challenged per facility protocol. However, based on nurse assessment, the staff were able to secure an order and successfully challenge patient. Clinicians were able to rely on the percentage change in blood volume in real time to assess this patient's ultrafiltration tolerance. So, when the blood pressure decreased to 111/79, the staff were comfortable to change the frequency of blood pressure monitoring rather than reducing ultrafiltration goal or administer saline. Without access to Critline data, staff would not have been able to assess fluid status throughout treatment. Strong clinical evidence supported the change in EDW prescription.
In summary, Critline transforms dialysis care by providing real-time insights into patient tolerance, optimizing fluid removal, and preventing complications. It helps identify at-risk patients and allows clinicians to monitor plasma refill with precision. By integrating Critline into practice, we enhance both patient safety and effectiveness in dialysis. Please stay to the end to access the post-survey QR code. Your feedback is invaluable. Thank you all for your time, attention, and participation. To receive your stipend, please complete the post-survey using the QR code or URL on the next slide. Ensure the last 4 digits of your address and employee ID match in both surveys. Your participation in both surveys is essential. Please take a moment to complete the final survey using the link sent via text or email, or by scanning the QR code on the slide. Once your pre- and post surveys are submitted and reviewed, you will receive your stipend via Venmo or Zelle using the address or phone number you provided. Coming together as stewards of care and serving those in need, we honor the greater purpose that we are called to fulfill. Here are the key resources used in this presentation. And this concludes my presentation on optimizing fluid management in hemodialysis using Critline technology.